All right, thank you, sir. Welcome to the October 21st meeting of the joint CRS-KRS Retiree Healthcare Committee. At this time, I'd like to call it to order. May we have our opening statement, please?
Yes, sir. This is a regular meeting of the CERS and KRS Joint Retiree Health Plan Committee. This meeting is being broadcast via video teleconference pursuant to Kentucky Revised Statute Section 61.826 and may be viewed by the public at the Kentucky Public Pensions Authority offices located at 1260 Louisville Road in Frankfort, Kentucky. It is also being broadcast to the public via Facebook. If you are speaking and are not appearing by video, please identify yourself before talking. In the event the video or audio broadcast is interrupted, we will attempt to reestablish a connection. If a connection cannot be reestablished within 30 minutes, the meeting will be adjourned and rescheduled to another date. Thank you.
Thank you, Mr. Board. Ms. Rankin, roll call, please.
Yes, sir. Mr. Powell?
Here.
Mr. Fulkerson?
Here.
Dr. Miller?
Here.
And Mr. Piercy?
Here.
Thank you.
Thank you. All members are present. Ms. Rankin, also, I understand we have a public comment.
Yes, sir. We have one public comment, and I will read that now. This comes from Rose King, and she states, why doesn't members that are enrolled in the Humana Medicare Advantage plan have full vision, dental coverage, money card to use for groceries and other benefits we don't receive with their premium coverage? We pay Medicare premiums and $1,800 plus co-pays out of pocket. So with retirees' health coverage being well funded, why? Without a COLA raise for 11 years, why can't we get better health care coverage at least? Thank you, Rose King.
Thank you. Next on the agenda will be the approval of the minutes from the September the 3rd, 2024 meeting. Has everybody had a chance to review them? And if so, is there any comments, corrections, deletions, any modifications?
Motion to approve.
Hearing none.
Second.
Have a motion to and second. All in favor, say aye.
Aye. Aye.
Aye. Opposed? Motion carries. Next on the agenda will be the Humana presentation. Ms. Whaley.
Yes, Mr. Powell, thank you. And I apologize that Larry and Tracy weren't able to be with us today. They are actually conducting some member meetings. I don't remember if they were for KPPA or for another group that we're working on, but anyway, they weren't able to be here. So Carrie and I think most of the presentation is going to be given by Carrie and another associate. So I am, without further ado, I'm just going to turn it over to Carrie. I think, Carrie, we're jumping right into the agenda. If you'll flip to the next slide, I'm not sure if there was anything. We are going to be talking about the 2025 drug list changes and pharmacy updates, and then an update on the pharmacogenomics, and then answer any questions. So Carrie is pretty much your show today. So I'm going to turn it over to Carrie Lovell.
Good morning, everyone. Yes, as Carla said, we just have two main topics we want to review this morning. The first is your 2025 drug list changes. We get together every year and just review some of the highlights of the most impactful changes for the upcoming year. And then the second portion of our presentation today will be just to touch base on pharmacogenomics. Every year, our Pharmacy and Therapeutics Committee, along with our clinical team, reviews all of the medications on our formulary. And the reason we do this on an annual basis is because every year new products come to market, brand new drugs enter the market for the first time. Some medications may lose their patent protection and we may have new generics available on the market. We also receive clinical updates. Medications may receive a new indication. They may be able to be used for something that they have not been used for in the past, or there may be a new risk that they're being used off-label. And then finally, we review pricing. The prices of medications can change. They can go up and down over the course of the year. So we do review all medications annually, and we make our drug list changes effective for January 1 of each new plan year. On the next slide, you're going to see just kind of a summary overview of some of the metrics related to the drug list changes for 2025. We typically break it down into our main categories of medications that will be removed from coverage, medications that will have prior authorization added, medications that have step therapy added, and negative tier changes, meaning medications moving to a higher tier. A couple of things that I do want to explain about the statistics that you see in front of you. Your negative impact number looks a little higher than what we've seen in the past. And when we move to the next slide, we'll talk a lot about why. It's really not going to be as impactful as it looks. We do have a PA going into place on our GLP-1 products, and we'll talk about that on the next slide. But I just don't want you to see this number. It's a little higher than it's been in years past, although it's comparable to what we saw back in 2019, I think. But I'll explain that the impact here won't be as significant as it looks. Also, we do have some positive changes that go into effect. And when we talk about the positive changes, these are the medications that are moving to lower tiers, medications where we might be removing a step therapy, removing a prior auth, or adding coverage. So the positive changes are what you see at the very bottom. All of the percentages that you see here were calculated based on 61,469 members. And just keep in mind that within the tier change bucket, we do have a few medications that would be moving from tier 3 to tier 4. And that's actually not a negative cost impact for your members because the cost share is the same. It does change the day supply that's available to them, but no real cost impact. So 253 of that 1780 that you see won't even have a cost impact with the negative tier change. And the primary prior authorization impact that you see related to GLP-1s, if we took that out, our total negative impact would only be 6.3%. So as we move on to the next slide, we'll talk a little bit about what that means and what that's going to look like. The first thing that you see here at the top of the page is our coverage change. And this was a CMS-driven change. They are moving all of the oral phosphate binders that are indicated for the control of serum phosphorus in patients with chronic kidney disease to Part B coverage. So even though it's reflected here as a coverage removal, all of those are still going to be covered. They're just going to be covered under Part B instead of D. So it's really a coverage change, not necessarily a coverage removal. And that was the majority of the coverage change impact that we saw for this year. So just as a reminder, what you see here next to each green bullet is the total impact. And then underneath are kind of the top impacts for each category. So those numbers underneath aren't going to add to 189, but this just shows you that just these two agents alone were the bulk of that coverage change that we'll be seeing. As we move on to the next category, we'll talk a little bit about prior authorizations. And here you see 8,347 members, but 6,850 of those are on GLP-1s. And as most of you probably know, the GLP-1s are those categories of diabetic medications, the Ozempic, Trulicity, Mounjaro, Victoza type medications. In 2024, we managed those with a point of sale edit, where our system did an automatic look back to see if a member had type 2 diabetes. And if they did, the claim paid and prior authorization wasn't required. Our automatic look back in the system checked for a history of other diabetes medications, checked their medical records. It was all automated so that members who did have diabetes were able to get those medications due to that systematic look back at the point of sale. In 2025, we are continuing that process, but we're also adding a PA to these medications. However, everyone who was approved with that medically accepted indication in 2024 will be grandfathered, and they won't even experience the PA. So 6,850 members are on a medication. We are adding that PA designation to our formulary, to our drug guide, but they will be grandfathered with authorization, and they won't have to get PAs if they've already been approved for diabetes in 2024. So that really takes the impact down, to a lot less than it looked initially. But I'm sharing it with you just for the sake of transparency, just so you know, we would be on the formulary adding a PA designation to those products. The next highest impact for prior authorization is.
Can you hear me? I got a question around the GLP-1s. Out of those 6,850, did you say how many were for weight loss versus diabetes, or do you know that?
Well, those I don't have that broken down,
Okay.
Connie. Those
That's
are
fine.
just the total. Those are the total users.
Okay.
But if they really shouldn't be using it for weight loss, because we did put the edit in place for 2024 to check for medically accepted indication. So if they are using it in 2024, and this is what we based the data on, they should be using it for diabetes.
Thank you.
Yes, because that's all that these particular ones are indicated for. So that's what we did the medically accepted indication check for at the point of sale. So this should be diabetic users.
Thank you.
Sure. All right, moving on to Restasis. Restasis is for dry eye. And this was one of our products where we did extend the brand. We've talked about that some in the past. Our extend the brand program is where we continue to prefer a brand name product if the generic comes to market and it's very, very expensive. Sometimes we wait for the price of that generic to fall before we start preferring the generic. So we're discontinuing extend the brand on Restasis, and the generic equivalent, the direct generic equivalent for it, cyclosporin eye drops, will be covered at tier 1. So the brand will require a PA, but they can get the generic at tier 1 with no PA. The next category for prior authorization impact was testosterone injection. This is, replacement therapy for medical conditions, not the age-related low T, but the actual medical conditions. And it is covered on Medicare when it's for a medically accepted indication. And we are adding PA because CMS saw about a 25% increase in utilization on this between 2022 and 2023. So that PA is being added just to ensure appropriate utilization. Our next category is step therapy. The first impact that you see here is for Climpic bowel prep solution. We are adding a step therapy to that, and Sutab, which is an oral tablet rather than a liquid, will be preferred at tier 2. The next one is Alpha-GAN eye drops. That's for glaucoma and ocular hypertension, and it helps reduce intraocular pressure in patients with glaucoma. Extend the brand on this one is also being terminated, and the generic equivalent, bromonidine, is going to be covered at tier 1. So it's just to add step therapy to the brand because that generic is available at tier 1. Now, this one is a little tricky because there are different strengths of bromonidine, which is the generic for the Alpha-GAN. And this particular strength, we are adding a step therapy to it as well, even though it's generic, because it is far more costly than the 0.2% strength. So the 0.2% strength is going to be covered at tier 1. And then this one will have a step therapy on it because this particular strength is significantly more expensive than the other strength. Then as far as tier change goes, Restasis, which we just talked about, that one is moving from tier 2 to tier 3 because it's going from that preferred extend the brand position. We're terminating that and we're preferring the generic at tier 1. So it's moving up to tier 3. Victoza is for diabetes. It's also moving from tier 2 to tier 3. Our preferred GLP-1s will be Mounjaro, Ozempic, Rybelsus, Trulicity. Those will still be in the preferred position at tier 2. And then finally, Wegovy is going to be moving from tier 3 to tier 4 because it does meet the CMS defined specialty cost threshold. So it will be moving up to tier 4 with a prior authorization for coverage only if patients meet the criteria for preventing heart attack and stroke in obese patients with known heart disease. So that one will be moving up as well. But as we mentioned before, a tier 3 to tier 4 move, there's no cost impact for members. It's just a day supply difference. So as we move on to the next slide, we'll talk a little bit about some of the communication that members receive. They are probably already receiving now in October, November, December, and January. They receive a drug list change insert with messaging in their SMART summary. And that is based on claims that they filled in the prior month, just to let them know that they have filled a prescription for a medication that may be changing in 2025. We also do a targeted letter that goes out in mid to late November that lists any changes that may be impacting a member and provides them with possible alternatives that they could use instead and next steps for them to discuss with their provider. And then finally, the transition fill. We do allow a 30-day transition supply in the first 90 days of coverage in a new plan year, and that's available to members who are impacted by changes to their Part D coverage for any drug that is transition eligible. Now, the tier changes do still apply. So if there was a copay increase, the member would still pay a higher copay in that first 90 days. But if, for example, they're taking a medication that requires a PA or a medication that's no longer covered, they would be able to get one fill of that after the first of the year while they work with their provider to get prior authorizations in place. All right, now we'll move on to the pharmacogenomics update. Over the past few years, we've had several discussions about pharmacogenomics. We've talked a little bit about the pilot that Humana conducted. We began that pilot back in 2021. The pilot itself concluded in early 2023. And then due to the types of things that we were measuring, the evaluation of that data that was collected was ongoing in Q4 of 2023 and into Q1 and Q2 of 2024. That amount of time was necessary to determine if the outcomes and return on investment would support a larger rollout as a Humana product. The pilot looked at genetic testing as far as the value in guiding therapeutic decisions. We looked at the impact on outcomes like hospital readmissions, hospital admissions, cost of care, medication adherence. And the purpose of the study was really to determine if we wanted to apply it across the board. So as we move to the next slide, this just provides a really high-level outline of kind of the steps of the pilot. The first step was to identify and stratify the population so that we could provide a targeted intervention list of members. Then we worked to enroll and engage the members by reaching out, and we have a slide that shows kind of what we did there. We contacted members about enrolling in the program, and then we shipped out test kits so that members could perform the testing. We had specially trained pharmacists that were ready to, process the pharmacogenomics analysis and notify members of the results, and then make recommendations to providers via both electronic medical record, phone, and email. And then finally, the final step in the pilot was to monitor the outcomes, to look at the open interventions, to monitor for medication changes, adverse drug reactions, and then really quantify any total cost of care savings. So the different types of drug-gene interactions that were identified in our test population are listed here. And you can see they, cover a wide range of different conditions, different medication types, and disease states. At the bottom of the slide, what you'll see on the left under the letter column, we sent out 11,115 letters, and we only had 1,043 tests completed for a 9.4% engagement rate. So the engagement rate was pretty low. In the middle, the my chart, and to the right, the phone stats that you see, those are not in addition to the letter, those are subsets of the population that received the letter. So they received extra engagement after they received the letter to try to boost that participation rate, but it just landed right around the 9.4%. That's the overall engagement rate. So what we learned after conducting the pilot was that member participation was low. And it took a while to get that 1,000 members that we were looking for. That's why the pilot took a little longer than expected, just because that engagement and participation rate was so low. We didn't want to move forward without 1,000 members enrolled, and it took a while for that to happen. Provider acceptance of the recommended interventions was also very low. We only had a 6% acceptance rate of the recommended changes in medication. So our outcomes didn't really show statistical significance, and we did not have the data there to support positive impact or value. So the outcomes that were found, combined with literature that's available today, didn't demonstrate enough of a positive ROI to justify scaling the program across our membership. However, if we move to the next slide, Medicare does provide some coverage for pharmacogenomic testing. We have reviewed this particular slide, I think, before, but CMS does not cover tests for predictive purposes like broad panel testing. So if a member does not have signs or symptoms, this type of testing is considered screening. It looks for variations in, multiple genes across a lot of different types of medications, and those types of tests are not covered by CMS under Medicare. Single gene tests, however, are more focused. They look for genetic interactions between certain medications and genes, and those are covered when medically necessary under Medicare plans. We have an example here that shows a situation where that type of testing would be covered, and only if it's ordered by a physician or a qualified non-physician practitioner would it be covered. The types of things that you see on the commercials on television, those are not covered. Right now, we're not aware of any changes to the CMS coverage for 2025. And I have provided a couple of links, just, if you're curious about the language or the verbiage that CMS uses regarding their coverage and how they cover testing or when they cover testing. There is an article here that gives some really good verbiage. This link is not really to go into a big discussion on billing or coding, but it does provide some good language around their genetic testing policy. And then in the appendix of the presentation today, we also have some verbiage from CMS about their coverage. And I've also given you a link if you would like to go in and read more.
All right, thank you. Is that it for you, Carrie?
That is it.
I had a question, Carrie. Just that population you did the pilot on, it wasn't all KPPA retirees, right?
No, it wasn't KPPA retirees.
Your book of business or a certain book of business?
Yes, yes.
Okay, thank you.
Do you think maybe some of the low engagement is because people aren't familiar with the testing?
You know, it could have been. I'm not certain around the details of the low engagement. I don't know if we got any feedback on that. I do have Anita on the line today, and Anita, are you aware of any feedback from members or any observations around why participation may have been low?
Hi, this is Anita from Humana. We did receive some feedback. Some members were not familiar with it, but we did provide them education and an opportunity to speak with our pharmacists and the genetic companies advisors for more information. So that was available. We weren't able to identify what factors specifically led to low engagement, though. That may have been a factor for the survey, but it's difficult to determine, really.
Because
Thank you.
that's my concern would be, because I think it's a valid program, but I do understand, the lack of engagement not making it a very good for your ROI. So I wonder if sometime maybe down the road could do an education what pharmacogenomics is, and you get people that, well, what are they going to do? What is that? And what are they going to do with my DNA? Have an educational blitz to educate them, and then maybe try it again down the road.
You know, it's something we'll certainly be monitoring. The science is always evolving. It does take quite a bit of effort to do these studies and quite a bit of time because you have to look at the data long term. We can't
Right.
determine those impacts instantly. So, but we will definitely, continue to monitor the science as it evolves. That's what, Anita and her team and others in our organization are constantly doing. We also stay updated on what CMS is covering, and we tend to really, follow their coverage of the testing. But that's, I don't know of anything planned in the near future to repeat it, but I think if something should happen to change in the marketplace or change with the science, then it would certainly be worth revisiting.
Okay. Anybody else have any questions on in this section? All right, thank you. Now for the Humana updates.
Mr. Powell, I'm not sure I have any other updates, and I'm not aware that Carrie does. So unless you all have any
Okay.
particular questions, I think that was what we had prepared for today.
Okay. All right, then thank you. Then next on the agenda is the open enrollment. Ms. Sutherland.
Good morning. We'd like to give you kind of a stance as to where we are from October 1st through October 13th with the KHP enrollment. It looks like our online web enrollments are pretty steady as they have been in the years past, along with how many forms we receive to process manually. If you'll go to the next slide. The Form 6256 is the form our hazardous duty retirees are required to complete each year. That is so their dependents can receive health insurance contributions. Again, we are really stagnant on the numbers between last year and this year, so it looks like we're right on track. And for our communications, our phone calls are down a little bit this year. As far as our emails, there is a correction to this. It looks like the second number was left off of this in the display. There were 89 email communications last year, and there's been 75 this year. And our visitors have been about the same as last year as well. For our next slide. This is our email notifications. We sent about the same number of emails last year. We did have more members view the email. There was a downside in the links, but this is a non-mandatory and no change required open enrollment for KHP. And for our outreach,
About that number, Abby, go back to that 500 versus the 1,000. We did a little bit different approach this year. We sent out a retired newsletter the 1st of October that had the links, open enrollment information, and so forth, which is a little bit different from last year. And then we also took the step on the 8th, which is the second week of October, and sent out a newsletter. So we are thinking between the two, they did a lot of the review the first, but I'm not sure. It's kind of just a little bit different, longer, more outreach, but still less, I guess, clicks or links reviewed. But there's no changes to the plans, and there's no changes to the Kentucky Employees Health Plan premiums. So that may explain why there's less of that seeking that the links. I don't know. It's just a little bit different and unusual. Thanks, Abby. Sorry.
okay. And then as far as our outreach, these are the benefit fair attendants that we've had. And there is one number also left off on the Russell benefit fair. That should be 11. So per usual, the Frankfurt benefit fair was our largest attendance. And then we do have an updated number on the webinar views. At the time we had received the data through the 13th, there was about 218 views. That has now had an uptick to 630 total views. So they are going to the webinars and they are watching them to get more additional information. Do you have any questions? Okay.
Give a bigger
All right.
picture. We'll give a bigger picture of this in September with complete data, all of these categories, and it'll give you a better idea of how the open enrollment went for the Medicare retirees, because that's just starting today through the end of November. Thank you all.
All right. Thank you all, both Humana and our very own healthcare team. Is there anything else you wish to bring forth? Hearing none, we have completed our agenda. If that's so, we will go into adjournment till our next scheduled meeting.